right, shall we? Well, welcome. Good afternoon, everyone. I would like to go ahead and call the Health and Hospital Committee meeting to order at this time. I am Supervisor Ardo Lee, Chair of this committee, along with our Vice Chair, Supervisor Margaret Abe-Koga. With both supervisors present, we have a quorum. Moving to item number 2, which is a public comment reserved for the public to address committee on any items not on this agenda. Any public wish to address the committee on items not on the agenda should request to speak at this time.
We do have one request to speak online.
Okay, so for that, we will go ahead and set the time for 3 minutes for that one speaker and close the queue. Go ahead.
Next speaker is Ben Z. You'll have 3 minutes to speak. The timer will start when you begin speaking.
Yes, hello, good afternoon. I've been trying to get help from this committee for quite a long time now in regards to my children who are being sexually abused. I've been trying to get a screening for my children, but the county is refusing to do so in spite of all the serious things that have been happening with my kids. Number one, my son, he's reported that my ex-wife was letting somebody rape him beginning at the age of 13. There was unnecessary bathing with the children. Thirdly, there was one child was repeatedly rubbing his pelvic area against the rectum of another child. And there was also abrupt changes in the children's personality. Like my daughter, she went from being very, very social and happy and having lots of friends to all of a sudden complaining that she had no friends, and she became withdrawn and anxious all the time. And then my son, he says that he's suicidal, he's depressed, and he's taking a lot of drugs to numb his pain. And I mean, these are all indications that the screening needs to be done. And I've been coming to you guys. I mean, we have MDs here who are on this committee who are mandated, not reporters, mandated actors. And there's Paul Lorenz. I mean, he's signed the sexual assault response protocol for the county. And within that protocol, I mean, we have protocols for children. I've read the protocol that he signed, but nobody on this committee is willing to help me, and I don't understand why you wouldn't do such a thing. I mean, if it was your kids, I'm sure, 100% sure, that you guys would want a screening for your kids, and you want something done. You'd want your kids protected, and you want them treated, and you get all the proper treatment, but yet you guys are ignoring me, and I don't understand what it is. I mean, would it in fact be a favor to me if you guys acted? Because, I mean, like, just tell me what I need to do to get my kids screened. Just tell me, what do I need to do to gain your favor? I mean, I know this is happening to other children. I mean, Violet Brooks and Catherine Campbell and Daya Peron. I mean, there are countless other parents who complain that the county ignores them when it comes to the sexual abuse of children. Otto Lee has all my information. I mean, you can talk to him, get my information. Please help me. Thank you for your time.
That concludes our request to speak.
Yes, thank you. Now, moving to item number 3, which is approving the consent calendar and changes to the committee's agenda. I actually have a couple of suggestions to add to consent, namely item number 6 and item number 10. Item 6 is a report from the Santa Clara Valley Healthcare relating to a medical social worker position on the obstetrics and gynecology urgent care clinic. And item 10 is a report regarding the tobacco retail permit program. Supervisor Abe-Koga, do you have any additions or changes concerning the agenda?
No, that is fine with me. Should I, is that your motion?
Sure, so if you have no changes, can I get a motion to approve the agenda as amended?
Yes, I'm happy to make the motion to approve the agenda as amended. Thank you.
Great, and I will second that. So any members of the public would like to address the committee on the consent calendar items should come in this item. And clerk, do we have any speakers?
There are no requests to speak in the room, and there are no requests to speak online.
Okay, good. Go ahead and close the queue, and let's go and take the vote.
Vice Chairperson Abikoga.
Aye.
Chairperson Lee.
Aye as well.
Motion carries.
Okay, thank you. Then moving to item number 4 on the agenda, which is the recommendation relating to medical staff and allied health professionals. I believe this afternoon to present this item is that Dr. Patricia Salmon? Yes, good afternoon, please. Oops, not working yet. Let's try again.
Good afternoon, Supervisor.
Much better, thank you. Good
Thank you.
afternoon.
Um,
Yes, go ahead.
Yes. I'm Patricia Salmon. I'm the Enterprise President of the Medical Staff for Santa Clara Valley Healthcare. Here to present the items on the agenda. Here to answer any questions for the committee.
Great, thank you. So let me see, first of all, there's no public would like to speak on this item, correct, clerk?
There are no requests to speak.
Okay, good, yes, Supervisor Abigail, do you have any questions, no comments? If not, I'll entertain a motion to receive and approve these recommendations.
Motion to approve?
I'll now go and second that.
Thank you.
Let's take the row.
Vice Chairperson Abikoga.
Aye.
Chairperson Lee.
Aye as well, thank you.
Thank you.
That was easy. All right, moving to item number 5. On the agenda is report from the Santa Clara Valley Healthcare relating to increasing colorectal cancer screenings. I'll let our staff to situate yourself, and please go ahead and introduce yourself, please.
Good afternoon. My name is Nimish Shah. I'm Chief of GI in the Center for Digestive and Liver Health at Valley Medical Center.
Good afternoon. I'm Dr. Dolly Goyle, Chief Clinical Officer for Population Health and Managed Care, responsible for a lot of our quality programs around these supplemental payments, of which colorectal cancer is one of the quality measures that we track. So we're here to basically, Dr. Shah and I and team put together this report that is in your packet, and we are here to answer any questions or any concerns you have.
Thank you. First of all, do we have any public who would like to speak on this item? Any questions?
There are no requests to speak.
Okay, I'll go ahead and close the queue. I do have a few questions on this item, but before I ask, let's ask my vice chair. Do you have any questions or comments on this item?
Thank you, Chair. No, just that I was really pleased to see the report, and it seems like we're on a good track. And so I just wanted to say thank you, and I appreciate the good work that's being done. Thank you.
Great. So let me start with some of my questions here, please. It is very good to read about the incidence and prevalence being stable or decreasing across all the racial ethnic groups between 2017 to 2022 regarding the colorectal cancer issues. It's certainly also even more exciting to read that the EPIC campaign module has now yielded a conversion rate of 23.2% within the first 3 months of this effort, which translates to about actually over 4,600 fit test kits being returned. And of course, this is the kind of work that will help us improve the health and well-being of our county residents and CVH patients. So a follow-up question I have would be, given some of the data with some of the African ancestries and Latino residents having high mortality and incidence rate as related to the other racial groups, how can we do better to target these populations to provide the services they need, the resources they need?
Yes, that's a great question. And so the Center for Digestive and Liver Health has broad outreach efforts. Every March, to coincide with National Colorectal Cancer Awareness Month, we hold a very large educational event at the main Valley Medical Center campus, which is hosted by GI physicians, advanced practice providers, nurses, nutritionists, and other team members. We have bilingual staff there, and we have educational materials in a variety of different languages to be able to help bring awareness of colorectal cancer as well as the need for screening. This past year, we had over 300 unique visitors attend. It was very successful. And for the first time this upcoming March, in addition to the annual event at the main VMC campus, we'll be hosting an additional colorectal cancer awareness event in South County at St. Louis Regional Hospital. So that will allow us to target our South County patient population as well.
Some of the other items are that in EPIC, Spanish is actually an available language. So for our Hispanic population, if they write that their preferred language is Spanish, we do all of our communication in that language to them through My Health Online, through the campaigns module, through email, and through text. So we are trying to outreach to them quite a bit. And the last piece is that the state actually does also require us to address disparities. So we have processes in place whereby our population health coordinators get reports that show them the various ethnic groups of patients that they need to outreach to. So they have priority given to patients that are hard to reach, and then we take quite a bit of effort and time to outreach to patients that don't normally try to come in. We are also partnering with our health plans to see if they have, because a lot of health plans will pay, they will offer incentives to patients to come in and get their screenings done. So we are partnering with our health plans on that process as well.
Great. You mentioned the population health coordinators. How many of those do we have, and how do they reach out to the patients who haven't yet completed the fit test?
Yes, I'm happy to talk about that. So we have currently 11 population health coordinators that manage a long list of quality measures and screening outreach. And 3 of them are dedicated to colorectal cancer screening. So the way the process works is they receive a report. They first call the patient to verify that they have the correct address, because as you might know, a lot of Medi-Cal patients' addresses aren't always current in our system. So first they call the patient, they verify the address, they explain the importance of the colorectal cancer screening. They explain that they're going to be receiving a fit test in the mail, and that once they receive it, how they should perform it and make sure they put it in the mail and drop it back off right away. They also explain that if they don't want to put it in the mail, they can drop it off at any of our clinics. In the lab, there is a box that's actually labeled, and they explain that as well. They do call them in the language that the patient has listed as their preferred language, so there is always that communication. And then after that, what happens is then we do the campaigns outreach to the patients who haven't returned their fit test. And then if the patient doesn't respond to the campaign, then the population health coordinator then picks up and then starts calling patients and and reminding them to return the test.
Got it. Thank you. So based on some of these questions that our office have been asking, first of all, thanks for responding so diligently and timely before this meeting. I would like to make a request that the administration provide an update, say 6 months from now, on targeted outreach to our African and Hispanic populations. Is that doable? Yes.
Yes.
Yes. No, we are doing great with the increased outreach and reminders through our EPIC campaign, and I would like the administration to focus more efforts, right, from the existing staffing we have on these populations that need our support the most, clearly. And with that, is there a motion to receive the report and forward to the board?
So moved.
All right, and I'm going to second that as well. Let's call the roll.
Vice Chairperson Abicoca.
Aye.
Chairperson Lee.
Aye as well.
Thank you.
The report's been received. Thank you very much.
Thank you.
Thank you.
Okay, item number 6 has earlier been moved to the consent, so we're moving to item number 7 on the agenda, which is the report from the Santa Clara Valley Healthcare related to regional medical center contracts. I believe we have who's here to...
Thank you,
Oh,
Supervisor.
Paul, I'm sorry, Paul Lawrence, of course. Good afternoon,
Just
Paul.
a quick report and update. As you recall, your board asked that we report back on this delegation of authority. I'm pleased to report that in most cases, with the exception of few, we are not assuming any contracts, and we are making amendments to our existing contracts as we begin to operationalize Regional Medical Center. So in this report, you will note that we've shared with you some of the agreements that we have amended, and we will continue to report back if we, in fact, exceed the authority.
Well, thank you, Paul. First, do we have any individuals who would like to speak on this issue at all? Clerk?
There are no requests to speak.
All right, I'll close the queue on that. I do have a few comments on this item, but Vice Chair, do you have any? Oh, you want me to go ahead? Yeah, sure. So first of all, thanks for the really thorough report coming back, because these quarterly report will be certainly helpful for our committee here at HHC to review what type of resources and funds is being spent on our vendors to complete the important acquisition, to ensure a smooth transition to county operations and bring the clarity to the public at the same time. And so I want to first acknowledge and thank our former supervisors, Sumitian and Chavez, for making this motion before. And with that said, I do have a few questions. Are the costs of these contracts that or what we expected, or are we actually running into an issue of cost overrun from the anticipated costs from previous estimations?
Supervisor, so as you well know, we are still early in the process, but at this time, there is no indication that we are going to have any issues around cost overruns relative to overall appropriations for this project.
Good. And we noticed that there are two different vendors, Diagnostica, Stago Inc., and the Roche Diagnostics Corporation, showing the $0 MFO value allocated to their RMC. So maybe you could help explain the
Yeah, I can speak to that, and we're going to remove this column on a go-forward basis because it's misleading. But basically, for certain contracts that are system-wide contracts, there's allocation that they're trying to make to certain cost centers associated with regional or not. But for certain of these contracts that are basically kind of being drawn down on central basis, they haven't allocated a specific MFO to regional. But I don't think the column adds any actual substantive value, and I think it's actually confusing. And so I've asked that on a go-forward basis it be removed, because I think it's misleading information. In other words, because we operate as a system, it's not like the contract is separate for regional. In fact, what we're trying to do, and one of the things, and just to explain one of the positive comments Paul made at the outset, when we did the 2019 acquisition, we assumed a lot of contracts that Verity had.
right.
And then it's taken a number of years to shift supply chains onto one centralized set of contracts for the whole health system.
Correct.
The good news here is, in part because HCA has a lot of proprietary system-wide contracts, we're not assuming as many contracts. And what we're instead doing, and as reflected on this chart, is actually amending existing health system contracts to add regional and the spend that we expect to have at regional. In the long run, that's of course much better, because we are then trying to move the whole system right onto one set of suppliers and supply chain. And there's lots of efficiencies associated with that. But that's also exactly why this concept of MFO allocated to regional doesn't make a lot of sense, because we're really trying to shift the model to looking at the enterprise holistically. So you'll see that column not there on the future reports, because like I said, it's not a useful one.
Right. So I guess my takeaway on this, James, correct me if I'm wrong, is that due to the fact that we already have existing contracts doing the same thing for the Valley Medical Health as a whole, we really are just putting those contracts, we really eliminate these duplications, right, that would have otherwise be. So this is all a matter of simplifying, getting things centralized, and potentially saving us money and work down the road. Yes?
That's right, and there won't, and in some cases that'll take a little time, because there's certain, of course, equipment or other things where, we will need to maintain separate maintenance contracts until end of life and replacement of that equipment and whatnot. But yes, the long-term goal, and I think it'll be faster with regional than it has been with the other hospitals, is one unified set of contracts for the system as a whole, unified set of equipment and supplies. That gives us cost efficiencies in negotiating, of course, but also in terms of maintenance and also in terms of redundancy, right? Because you can then move equipment also between facilities and sites as well. So we're really using regional as yet another catalyst across the board to take steps to continue to work towards an integrated enterprise. And that goes not just for supply chain, but for things like policies and operations as well. And we're going to continue to push on those on all fronts and really see regional as an opportunity to make expedited progress in those endeavors.
Right. There's certainly a lot of lessons learned from the 5-year goals when we acquired St. Louis and O'Connor through the process, and we have able to apply a lot of those lessons to make this transition as smooth as possible. And back then, I remember there was an uptake of work in the procurement staff. So wanted to check with you to see if you expect that to happen and whether our procurement staff current staffing is enough to support this RMC acquisition.
Yes, procurement is one of the departments that's affected, and for a bunch of the things you see here, these are contracts that are actually managed by the procurement department because they're supply contracts. So the goods contracting is centralized through procurement at the county. And, we have communicated to TSS, procurement, ESA, and others that this is the priority, so they've shifted resources here. It's not realistic to really, staff up with people who would have the expertise on our own processes, on the timeline of a 3-month transition. Very fast timeline here. It's not even, a full 3 months. So we've shifted staffing priorities. So for procurement, for TSS, for FAF, for ESA, we have shifted resources off of other things. And as I've communicated to all the department heads in the county, there will be delays in other work in this period while this project is taking priority resources.
And I know this, the report on contracts is currently on the quarterly basis.
Yes.
But as you mentioned, things are moving so quickly in this RMC acquisition, and you plan on giving us more detailed updates on the progress of this acquisition, both to HXC and the full board as we move forward.
Absolutely.
Yeah, great, thank you. Okay, without further questions or comments, as far as Abigail, may I receive a motion to receive the report?
Yes, thank you, President Lee. And I actually just did have the similar question about just receiving more frequent reports as we move along with this integration of regional. So I appreciate you bringing that up. And with that, I'm happy to make a motion to accept the report.
All right, and I'll go ahead and second that. Let's take the vote.
Vice Chairperson Abakoga.
Aye.
Chairperson Lee.
Aye as well.
Thank you.
All right. Moving next, I believe item 8, we have, yes, correct. Item 8 is, actually, I think there's a typo, so I just want to say it. The title says approved by, I believe, clerk. It should have been received annual report from the Public Health Department relating to epidemiology, grants, contracts, and services for the prevention and care of sexually transmitted infections, STIs, and human immunodeficiency virus, HIV, and hepatitis C virus for the period from July 1st, 2023 through June 30th, 2024. And I believe yes.
Yes, This is a
Cody, go
report
ahead,
from
go ahead.
Public Health.
Yes.
Thank you.
Good afternoon.
Happy New Year.
Happy New
It's
Year.
good to be here, and welcome Supervisor Abekoga. We have from Public Health my colleagues Dr. Sarah Rudman and Dr. Akanksha Vaidya. Akanksha leads our sexual health and harm reduction program and actually will be presenting the next two items. We have presentations for both, which we're happy to provide, or just take your questions as you wish.
Great, thank you. Go ahead, please, Doc. And welcome to HXC.
Thank you so much. Thank you, Dr. Cody, and thank you, Chairperson and Vice Chair. So you have the full reports with you about our STI and HIV programs and the harm reduction program, but I'll just go through some highlights and then I'll take your questions afterwards.
Great.
So starting here, you'll see the rates of bacterial STIs, which are chlamydia, gonorrhea, and syphilis from 2013 to 2023. The main thing to note really is that the rates of these STIs were rising pretty dramatically up until 2020 when we saw a drop in these rates. And this was largely due to the COVID-19 pandemic, which not only changed people's behavior, but we also know that it reduced testing. So that's why we think these rates dropped. So you do see that uptick in numbers in 2021 and 2022 as testing rates recovered. But the rates never quite reached what they were before the pandemic. And what's interesting is that in 2023, these rates have dropped again. While we need more data in subsequent years to figure out if this is an ongoing trend, this early data is actually a little encouraging. I wanted to bring your attention to this slide where we compare what we're seeing in Santa Clara County to what's happening in California and also nationally. And essentially, you'll see that the trends that we see in Santa Clara for chlamydia rates are very similar to what's happening in California and nationally. So notably, that drop in rates in 2023 is happening everywhere in California and also nationally. Similarly, for gonorrhea, again, our trends really mirror what is happening elsewhere in California and nationally as well. And again, those drops in 2023 are happening everywhere. So just wanted to point out that what we're seeing in this county is, again, very similar to what's happening nationally. Moving on to HIV, so here you see the rates of new HIV diagnosis in Santa Clara County. And it's important to note that our HIV new diagnoses rates have actually remained pretty stable for many years, as you can see in this graph. Again, in 2020, the rates fell, and we actually know now that this was most likely because of reduced testing, because in 2021 and 2020 as well, we saw a lot of late diagnoses of HIV. So we do think that testing reduced in 2020. And in some ways, it was reassuring to see the numbers going up because it meant that our testing levels were back to where they were supposed to be. So we are testing people and making sure that they are getting into treatment. But the rates are not going down. So the 2023 numbers here are back to where they were before the pandemic. And we know that we have more work to do to actually get the rates of new HIV diagnoses down. This slide here looks at new HIV diagnoses by race and ethnicity. You'll see that the yellow trend line, which represents new HIV diagnoses in people identifying as Hispanic or Latinx, shows that case rates are very high in this group and are continuing to go up. For the group identifying as African American or Black, you'll see two data points here. We had to suppress some data counts because this group overall has a smaller population in the county, so numbers had to be suppressed for privacy reasons. But still, with the two data points that you see here, you see that they have a disproportionately high case rate for new HIV diagnosis. And in the full report, which links to our epidemiological report, you'll see that this is seen in other STIs as well, so gonorrhea, chlamydia, and syphilis. This disparity really is concerning and something that we want to make a priority to work on. So when we think about why certain groups are disproportionately affected by STIs and HIV, we started thinking more about social determinants. So to look at how they're interlinked, we used a tool called the Healthy Places Index. What this tool does is it looks at resources that are available in different census tracts, and it categorizes census tracts based on available resources. So these resources could include things like access to jobs, access to education, clean water, clean air, resources which are linked to higher life expectancy. So in the first map, the areas that are marked in blue have the least access to these resources. Then if you look at the second and third map, which looks at case rates of HIV and STIs, you'll see that the areas where we have more HIV and STIs are the same areas represented by blue, which have the least access to resources. So what this really tells us is that HIV, STIs, and social determinants of health are just very, very interlinked, and we need to work on social determinants of health to really make an impact on the rates of STIs and HIV. So looking forward, there are a few things that we want to work on while working with diverse county and community partners. So the first is to increase access to STI and HIV preventative services, primarily for priority populations. And this could include vulnerable populations who've had lots of interactions with the justice system. It also includes those populations disproportionately impacted due to being in certain racial and ethnic groups, as we just saw. The second thing we want to do is increase access to STI and HIV screening for populations that are hard to reach. We know that there are certain people for whom the only access to healthcare or the only touch point with healthcare is the emergency department. Leveraging that as an opportunity to screen these people for HIV and STIs becomes important. And third, we want to, again, address the primary determinants of health because we just saw how interlinked they are with HIV and STIs. So lastly, while we're doing this work, another thing that we continue to work on is figuring out how to sustain ongoing work, knowing that we have increased demand for services, and also the fact that some of the grants that we rely on are sunsetting shortly. So we'll continue to work on that to ensure that critical services are maintained. So with that, I can move on to the harm reduction presentation.
You know, since we hearing item 8 and item 9 separately, why don't we deal with this one first
good.
before we
Thank
move
you.
to
Yeah.
item 9? Yeah, go ahead.
Happy to take any questions.
Sure. Any public would like to speak on this item?
We do have one request to speak online.
Okay, let's do 2 minutes.
Next speaker is Ben Z. You will have 2 minutes to speak. The timer will start when you begin speaking.
Yes, I think, one future direction, something we could work on better that was not mentioned in this presentation is when it comes to children. Children aren't just going to say, hey, I have an STI or I have an STD, right? We could be talking about a 2-year-old, which in my case, that was my youngest. And how can you do that? How can you do these types of screenings for STDs for a child who's being sexually abused when the sexual abuse is never addressed to begin with? Because nobody's going to assume that a 2-year-old has an STI, right? Because it's just crazy, unless there's sexual abuse. But look, Dr. Sarah Cody, right? She oversees the Child Advocacy Center, who does screenings for children, right? All those people, they do screenings. Dr. Sarah Cody, can you please help my children? You heard in the beginning of my public comments, I told you about the sexual abuse, right? I can't get anybody to help me on this. You are a mandated actor for the Child Advocacy Center. Can you please help me get a screening for my children, please? I greatly appreciate it. I don't know who else to turn to. There's a conflict of interest that's preventing the screening from occurring, and you should be above all of that, right? You get paid by the county to protect our children. Please, Dr. Sarah Cody, help my children get a screening. Otto Lee, he's got all my contact information if you need it. Please help my kids. I've already made a report to the DFCS. Thank you for your time.
And that concludes our request to speak.
Yes, I'll go ahead and close the queue for item number 8. Do we have any questions and comments? Vice Chair Abakuga?
Thank you, Chair. Yes, thank you so much for the presentation. What I guess I was particularly concerned about is in terms of ongoing funding, some of it's sunsetting, and was wondering if you have identified other resources so far, or is that still in progress?
Well, thank you for your question. I'm Dr. Sarah Redmond with the Public Health Department. It's a pleasure to welcome you here at HHC. But unfortunately, to your question, I think we don't have a satisfactory answer right now. Part of what the Public Health Department has been experiencing last year and to a greater extent again this year has been a withdrawal of many of the federal and state resources that support exactly this kind of work, making us even more reliant on county general fund, just as that general fund is also experiencing a structural deficit. So last year, in order to respond to the ways in which those grants, cliffs, and structural deficit impacted the department, we already had to decrease the team working on things like helping young folks without easy access to medical care get on PrEP, the medicine that prevents HIV. We've had to scale back that program, although trying as hard as we can to sustain it at the current level. And we anticipate that it's possible we'll scale back again further this year as those state funds sunset. So we continue to look for creative solutions, but we have not successfully found grants or in-kind support that particularly help us do this kind of work. We have continued to work closely with OBA to look for other opportunities, and we'll be open to really leveraging work with partners where we can to make sure we're making the most of what we do have.
James, go ahead.
Yeah, I would just add a little bit onto what Dr. Rudman shared. You know, public health nationally is really facing this kind of fiscal cliff from the withdrawal of significant federal resources. And to put things in perspective here locally, pre-pandemic, so, you know, federal funding increased during the pandemic, but pre-pandemic, the Public Health Department was dependent for over 40% of its budget on federal grants. So this is a function that even in Santa Clara County, which is a community that actually does have ability and has made significant local investments in public health, has historically and continues to heavily rely on federal funding. Of course, that's even more true in other counties and cities across the United States. So it's something we're very concerned about, not only the drop in significant federal funding in the last couple of years, but of course what might be coming our way with yet to be announced and probably significant reductions or even attempts to eliminate several of these programs. And if you've seen some of the litany of executive actions that have come just in the last 2 days, there's a number of programs funded in the public health space that are specifically geared towards dealing with disproportionality and underserved populations that are particularly vulnerable, that pretty clearly going to be targeted by this administration's just aggressive and really disturbing position on dealing with equity-related issues. So I want to just call that out as well, because public health is one of the places where we get some significant federal funding associated with those kinds of programs. So we'll keep monitoring what's happening. Of course, we'll continue to advocate, but we really don't have anybody to advocate to at DC, but you know, we'll keep saying what we need to say. And at the state level. So the other thing that I would add is one of the things that was really concerning in last year's state budget was the governor's proposal to heavily cut public health funding. The legislature actually pushed back on that, and we were able to avoid a lot of those cuts. But that's something we also have to keep an eye out on, because even though it's much less funding compared to the federal sources, it becomes all the more important to have that limited state support in the context of what's happening federally.
Great, thank you, thank you. Thank you, Chair.
Thank you. Yes, so the follow-up on that issue regarding the funding challenges we have, I noticed there is currently $5.9 million in the existing county general fund allocated to STI programming. Do you see any opportunity to potentially redirect, reallocate some of these funds to help better support these sexual health needs of our county?
Thank you, Chairperson Lee. I think you are spot on in flagging that strategy, and what's unfortunate is that's something that we've actually already done in the current fiscal year. We're fortunate, and we can speak about it in the next item, to get support from our behavioral health colleagues with funding some of the generally funded activities in the same team that were eligible for opioid settlement funds, and that are really focused on preventing overdoses at the clear direction of the board, and what we hear from our community that is a priority as well. And so with that, we have already redirected what we can of the general fund in the STD program to try to sustain some of this, as well as other pieces of the department that we know are board priorities and community priorities that are also in jeopardy. Beyond that, I think where we struggle is that while there's now less than that amount of general funds still in this cost center, much of it is working in the STI clinic. So much of it is doing exactly this work that we're describing. Much of it is in the STI clinic, where we're providing exactly the services for folks who aren't eligible or can't seek care in other settings. Or it is required to match some of those state and federal funding sources that we rely on. And were we to pull back either the money or the resources we use to comply with the funding requirements, we jeopardize other funding we have. So we're really stuck in this rock and a hard place where we are heavily reliant on highly specific outside funding sources that cause us to leverage what we do have internally as well.
No, thank you for trying so hard on kind of, I don't want to call it robbing Peter to pay Paul, but that's exactly what it boils down to at times, to see what the needs is the most, and if the funding is made available because it's not spent elsewhere, I think we need to be agile to make it happen. And then the other one I would like to check on is, would you please update me about the discussion between the Public Health Department and the Santa Clara Valley Health SCVH about any collaborations with the emergency departments for the opt-out screenings that's being done? Yeah.
Okay, well, I think, as you flagged rightly, I think part of what is so hard about preventing sexual STIs and enabling sexual health is that it does rely very heavily on our own healthcare system and healthcare systems that we know struggle to provide care for the people who need it most. So even in high quality, excellent healthcare systems like our own, we see that emergency rooms are struggling to do things that are recommended, such as universal HIV screening. So we are working very closely. We have the support of Mr. Lorenz and the medical leadership at SCVH to make this happen. We've had excellent support to do things like create automated systems in the computers to facilitate this, but we're just not across the finish line now just yet, and so we're dedicated to getting there.
Great. Yeah, and I just want to make sure moving forward, we will continue to follow up with you, to both departments, to make sure that these opportunities and collaboration on STI preventions is happening in our EDs. Yeah, thank you very much. So on that note, I would just like to go and say, let's make a motion to bring the set of STI program funding issues to the May budget process for discussion of the full board, since the LGBTQ community and the historically underserved communities are the ones who might lose the most if we're not able to continue to prioritize these STIs and sexual health services along with the associated social determinants of health. And may I get a second on that?
Yes, happy to second. Thank you.
Okay. Any questions from staff? That's all good to go? All right. If no more questions, let's go take the vote, please.
And Vice Chairperson Abekoga. Aye. And Chairperson Lee.
Aye as well. Thank you
Thank
very much. Now we get to move to item number 9 regarding the harm reduction program, formerly known as the Needle Exchange Program. Yes, please proceed. Thank you.
Thank you. Okay. All right. So I first wanted to bring your attention to this graph, which really shows how much the clients coming to our harm reduction program have increased over the years. In fact, if you look at fiscal year 2024, you'll see that we had a 40% increase in unduplicated clients compared to the prior fiscal year. The costs to operate this program have also increased in alignment with the increased clients that we're serving. But what's interesting is that the number of syringes that we're distributing has actually started to go down since 2022. So although we started out as a syringe services program, in 2020, in response to client feedback and also evidence showing that alternatives to injection reduce the risk of overdose and also reduce the risk of certain infections that are directly tied to injections, we started distributing alternatives to injection supplies. So these are supplies for smoking or snorting substances. And this decrease in syringes is probably due to the fact that we're increasingly distributing those alternatives. The other thing that happened around this time is that we launched our low barrier medication assisted treatment program, which again was launched in response to client feedback. So the program really aims to be low barrier and provide those navigation services and resources for people who are ready to stop using substances and give them the resources they need. So with that, so in addition to distributing safer use supplies, our program also distributes opioid prevention supplies, which you can see here. We distribute naloxone and fentanyl test strips and provide education to clients on how to use these. The demand for these has also increased over the years, as you can see in this graph. And in fiscal year 24, we distributed 29% more naloxone doses than the prior fiscal year and 57% more fentanyl test strips than the prior year. We also collect information from our clients coming to the harm reduction program on any self-reported overdose reversals. So we ask them, did you ever have to use Narcan for yourself or for anybody else? And they actually told us in the last fiscal year, that's 562 overdose reversals. And that really means 562 lives saved. In addition to the work that we've been doing with the harm reduction program, in 2023, we received a grant from the CDC called the Overdose Data to Action Grant. The real aim of this grant is to work together with county and community partners to reduce overdose in the county. So with that, we've launched a couple new initiatives that I wanted to talk about. The first is our website called odfreescc.org. This website really aims to be a centralized hub for overdose prevention information. So it has access to resources, so things like free naloxone, where to find medications for treatment, where to find safer use supplies, and also where to find things like support groups. It also has other key features, so it has a data dashboard. It also has a place to request training resources if you're a healthcare provider or even if you're a community partner. And in general, it has messaging around stigma reduction and ways to engage with our team. We've also launched a post-overdose support team program. So we know that after someone has a non-fatal overdose, their risk of having a subsequent fatal overdose is high. So it's really important to intervene during this vulnerable time so that we can really save lives. So post-overdose support teams are a CDC evidence-based intervention where teams really go out and make sure that people who have survived an overdose have the resources they need to prevent a subsequent overdose. So our teams with the POST program will go out to clients who've been referred and will provide them with resources like harm reduction supplies, naloxone. If the clients are ready to seek treatment, they'll provide them with resources on how to get into treatment services. They'll link them to care and provide a warm handoff. And we know how important things like housing and food are, so they will also provide them with resources to get those services that they need. In addition to the website and the POST team, other things that we are planning with the OD2A funds are things like harm reduction vending machines, which will really allow people to get the supplies that they need whenever they need them. We're also working to expand our partnerships with community health centers so that they have the education and tools they need, and also so that they have overdose prevention supplies. I also wanted to mention, it's not on these slides, but it is in your full packet, that we did last year do an evaluation of the various coalitions and committees that are working in the county on overdose prevention. And the recommendation was to create a overall joint coalition with multiple subcommittees. And I'm happy to announce that we'll be launching the first meeting of this new committee next week. So looking forward in this realm, things that we continue to work on are things like improving data sharing across county departments, and also understanding that there is a rapid increase in demand for these services, so we continue to look for ways to meet the demand and ensure that we provide this critical service to people who need them. Thank you. Happy to take any questions.
Thank you very much. Do we have any speaker on this item?
We have one request to speak online.
Yeah, 2 minutes, please.
Ben Z, you'll have 2 minutes to speak. The timer will start when you begin speaking.
Yes, I found it quite alarming that our costs have increased because we have more people using this program, because it does mean that more people are using drugs. And while it is effective that we give them needles and syringes and Narcan and treatment after an overdose, I mean, that's all good, but we should also be focusing our money on the conditions that cause drug abuse. For instance, we all know that children who are abused, they have a high likelihood of growing up and using drugs. And we're just, in this county, we're just not investing enough money in the prevention of child abuse, especially when it's been already reported. I know we had a special meeting after the death of baby Phoenix, at which James Williams, he said, you know, this is unacceptable and we need to overhaul the system and we need to make sure that this never happens again. And I know he's very concerned about this and about my kids. So I know that he does oversee DFCS. So I'd like to ask him, knowing all he knows about my kids, what I said and what I've emailed to him, could you follow up with Sarah Cody to make sure that my kids get a screening? Because I know that you've committed yourself to preventing child abuse and to lowering the rate of it. Can you please talk to her? You know that we just had a recent resignation, so I mean, we don't know what's going on there, and I mean, we know that they're not doing a screening for my kids. Please, can you help my kids, James Williams? I'd appreciate it. Again, you have my contact information, and so does Otto Lee. Please follow up with Sarah Cody. Thank you.
And that concludes our request to speak.
Yes, go ahead and close the queue on the speaking portion by public. First of all, I just want to, oh yeah, I do have a few questions and comments, but Vice Chair Abico, do you have any questions on this?
Thank you, Chair. Yes, thank you. Thank you, and thank you for the presentation again. I appreciate the information, the data. And I think it sounds like it's actually a good thing that the demand has increased of more folks wanting to seek assistance. You mentioned that some of the challenges being data sharing, and is that within the county departments only, or is there some with community partners, for instance, as well?
I think what we're, thank you for your question. I think what we're encountering is both a general enthusiasm and support for the idea that as long as we are very careful to protect the privacy of the people we are trying to serve, that there is an intention to share data across both individual county departments and across non-county organizations. We do encounter both logistic and legal barriers to doing so. So you can imagine first, the systems that house the death data from our medical examiner, well, I think some of the best in the country in how she shares those data are siloed from what the hospital has, which are separate from what EMS has, which are separate from what public health has. And so individual systems need to be created to understand the laws that allow us to share those with them, and then make very sure that we're doing so in a privacy protective way. And then on top of that, we encounter additional barriers when we try to understand the populations we're serving in ways that they access non-healthcare resources, such as housing support or interact with the justice system, where you can imagine there are other legal barriers to sharing those data. But our goal ultimately is to really see the big picture, understand the arc of somebody who is in and out of custody, is in and out of homelessness, and maybe at high risk of overdose, and make sure our systems are set up to serve exactly that person.
Great, thank you. Yes, I encounter privacy issues, really the barrier to so many of the areas that we work on, and I just came from transportation, and that's another problem there too. So I hope maybe my colleague here in the legal, that's a legal background, could offer some advice on that. But regarding the demand, again, seeing the increase, what are your thoughts in terms of how to address or to meet the demand that we're seeing?
Yeah, so We have a couple things that we're thinking about. So the harm reduction vending machines are one
yes.
idea that we have where, we'll have the same supplies, a lot of the, syringes, alternatives to injection supplies. And we will make sure that there is a way that is protected and that our clients can access it. But it's another touch point so that, we don't have to physically be present and people can get services when they need them. Another thing, as Dr. Redmond was mentioning before, we have collaborated with our Behavioral Health Services Department, and we are getting opioid settlement funds now. So this is helping us with much-needed expansions for the program to meet this increased demand.
Great. Thank you. Thank you, Chair.
Yes, thank you. First, I just want to say thank you for the harm reduction program, and that's interestingly put in the beginning. This started as mostly a needle exchange program, and how that certainly has changed. So would you say that the reason why there's less needle exchange is due to the fact that the way or the popular drugs of the day and delivery has also changed as well? In other words, it used to be more through injection, but now the choice of, like with fentanyl and what else out there with meth, a lot of that it does not require needles, and that's the other reason why there's less need of that exchange program as seen on the numbers.
Yeah, thank you for the question. It definitely, we do get a lot of intel from our clients. So they tell us, what they need, what they're seeing out there, and increasingly we're seeing an increased demand for these alternatives to injection. And it could be a variety of reasons, like you mentioned, the change in the drugs that are being used, but also the fact that there is messaging out there that, injecting drugs carries a higher risk of overdose, and using these alternative methods reduces the risk of overdose. So again, we educate our clients to use drugs in the safest way possible, and continue to educate them that whenever they're ready to stop using, we are there for them. So it is a shift in, I think, primarily a mix of education, possibly what is being used out there, but also understanding that clients do, listen to the education that we give, and it is spread in the community, and they are trying to reduce their risks in whichever way possible.
Right. Obviously, we are trying to serve as many county residents as possible, and seeing the fact that we have an increase of 40% of non-duplicated participants in this year certainly is a very good sign. I would call it a success on this. Now, also mentioned is that we have reversed 562 overdoses. That's documented. We know there's probably double the amount, but that's not been reported. On those 562 overdoses that we talked about, do we track to see how many of those might be of the same individual multiple times?
I do not know that we have that data. These are self-reported, so I can look into it and get back to you if we know how many were in the same individual. But this is exactly the thing we're trying to prevent with the POST team. So definitely, I think now that we've launched the POST team, we are telling our clients to self-refer to the POST team if they have experienced an overdose or if they have a friend who has experienced an overdose, to really prevent exactly what you're saying, where we don't want, the same person to have multiple overdoses.
Right. About 3 weekends ago, I listened to I think it's a podcast on NPR on the specific story of how they have a program of an individual staying on the phone closely for people who are going to use, and without a partner, as we know, that potentially could be an issue. So by having this very innovative, but also very controversial program, having this phone line to allow folks to call in, and so that when they are using it, and if for some reason they do not respond back within a certain number of minutes, the individual on the other side of a line could then immediately call the medical services of the location of the individual doing it, so that they would receive some type of urgent response that might potentially save lives. I don't know if this is something that our county has thought about participating. It seems to me it's a remote program. It doesn't have to be based in this county. It could be somewhere else. I just want to make sure this is something that we have considered, and maybe this is something you can bring back in the next report to us to see something that we could advocate or advertise to folks, because obviously if somebody they get first of all, we don't want people to use it, but the fact that that's not preventable, if they're going to use these drugs, that if they cannot find somebody on site with them, that this might be another way to continue in this harm reduction efforts. Is this something that you've heard of, and any thoughts you have on this?
Yeah, absolutely. You know, it is one of the harm reduction techniques that we tell clients coming to our program is never use alone. And really the goal is to save lives. So if they have someone with them, if they overdose, the other person can provide them with Narcan. Or as you were saying with the phone hotlines, there is someone else on the line, and if they don't hear them, they can send medical services. So the goal really is to save lives with all of this. So we do tell our participants about the various hotlines that exist for not using alone. So we definitely educate them about that, and that's part of the education that our team provides to the clients.
Right. We are now distributing a lot of Narcan kits, and those kits are not exactly cheap, as we know individually. Would you say the reason why we see the increase of expenses here, even though we distribute less needles, had to do with the fact that we're distributing a lot of Narcan kits that has driven the budget, or is there some other reasons?
We actually get our naloxone through the naloxone distribution project, which we get from the state. So we actually get that supply for free.
Great.
So most of our costs are the syringe supplies, alternatives to injection, and the staffing that is needed to provide the education, the supplies, and also our low barrier treatment program.
Okay. And the budget of $2.4 million, how much of that is actually being supported using county general fund approximately?
So at the time we prepared this, reflecting on the last fiscal year, that was a majority general fund with a small amount of CDC grant funds, federal grant funds, and some state funds primarily for infection prevention. In collaboration with behavioral health, we have been able to leverage opioid settlement funds to support this work, and that's part of how we've been able to offset some of the risk of relying on federal and state support and expand the program in exactly the ways Dr. Vaidya was describing. But I will flag that there is still a good deal of reliance on both federal funding via our opioid overdose data to action grant and on the kinds of in-kind state supplies that Dr. Vaidya just described. Were some of the discussions that I believe are coming out of the governor's office around how they plan to supply state harm reduction services change as they may, this could potentially impact our ongoing free access to these resources.
Well, we do know that the new federal administration, of all the different messages being provided, fighting against fentanyl overdose is one of their talking points. Do you see that this might be an area of cooperation? We could use our leverage with our congressional members to try to come up with some bipartisan funding coming through in the future regarding this issue?
I would certainly hope that that could be a possibility and that the kinds of work that prioritizes our most vulnerable community members in a way that embraces science to do so will be something that we will see support from. But I think it remains to be seen, and I appreciate that we have the support of colleagues here in OBA and the county executive to have a plan B.
Great, thank you. We talked about the Narcan kits. We also the fentanyl test strips, and it's really exciting to see that the fentanyl test strips numbers are so significant. So do we have some type of logistical issues moving forward? Do you think we need more of those based on the needs that we see?
So right now, we get fentanyl and test strips also from the naloxone distribution project, which is provided by the state right now. But as Dr. Redmond was mentioning, you know, we rely heavily on state funds, which I believe they get federal funds to sustain this project. So we'll just have to see how things go. But, you know, right now we have the supplies, but if things change in the future, that might change.
Good, thank you. How much funding is currently allocated for the Bay Area Medicaid Assisted Treatment Program? And is there a target number of individuals for the program that we're serving, and also who would qualify for this program?
So for the funding piece, that program is run through some funds that we get through the Sierra Health Foundation. Part of those funds go to a community partner who serves as our medical provider to see these patients. and then some of those funds come to our team who provides navigation services. The total amount of funds are probably somewhere around the lines of 500,000, but again, we get them, some of them go to the medical provider and then some come to us. With regards to the number of clients, we see anywhere from 120 to 150 clients per fiscal year. It depends on the fiscal year. There's no criteria to join the program except that you want to be willing to try medication-assisted treatment. So we try to keep it as low barrier as possible. Our team of navigators and health educators go to our harm reduction program sites. They talk to participants about this. And whenever someone comes to them and is like, you know what, I'm ready to try treatment today, they'll enroll them in the program. And our goal is to get them started on medications, ideally the same day.
Great. So would you say that from where you're looking at, there really is no no wait time? If the individual is ready to receive treatment, they should be able to get treatment the very same day in this county.
That is our goal. Yes.
Great. Thank you. So separately, I just want to mention that we have many work groups previously, and now we are moving forward to consolidate these work groups to improve the substance use and overdose prevention. And I just want to also say thank to the Public Health Department and Behavioral Health Services Department and all these stakeholders for being very responsive and willing to streamline these efforts on substance use education, prevention, and treatment. And so the other one I was going to check in is about the DUHAC as an independent advisory group, and whether it makes sense to fold that group into a broader umbrella group or have it as a separate subcommittee.
So the DUHAC, or the Drug User Health Advisory Committee, was created really to hear the voices of people who use substances and really get their input into the work that we're doing. We did ask for their feedback about whether they would like to be part of the larger coalition, and they did not want to. And the main reason is because this is a highly stigmatized group. So the DUHAC is a safe space for them to really voice their opinions and be able to really tell us what they think and what they need. So they didn't want to lose that safe space, which made a lot of sense. We do anticipate that a few members from DUHAC will join the larger subcommittee and be able to kind of provide information about what DUHAC is thinking, and will definitely serve, ensure that information in DUHAC goes to the larger coalition as well, just so that we can work on projects together.
Great. Thank you very much. As you can see, this committee is very excited and interested in your great work. So keep up the good work and keep us posted. And I'm ready for a motion to receive a report.
So moved. Thank you.
I'll go ahead and second that. Let's take the roll.
Vice Chairperson Abakoga.
Aye.
And Chairperson Lee.
Aye as well. Thank you very much. All right, item number 10 has been approved on consent, so we move straight to item 11, which is a discussion around emerging issues impacting our health system. And I believe we have Paul. Go ahead.
Thank you, Chair Lee, Supervisor Abakoga. Obviously, you have our written report, and I do want to share with you that in future reports, we will have a written update on our progress around the integration of Regional Medical Center into our healthcare system. So you will have a written report from us. Just to make a few comments, first of all, I do want to, again, publicly thank the two of you and the entire board for your support in bringing Regional Medical Center into our healthcare system, and the negotiation of the asset purchase agreement that James Williams and others worked on is quite monumental in terms of where we stand today. I am very pleased to report that we are making excellent progress in our planning and integration plans for the April 1 date. And as you well know, we are, again, going to bring back trauma services on day one, and that planning is going well as well. And I would also add that we are looking to also bring about STEMI and stroke services as quickly as possible, as well as many other services that the community has relied on in the past and are desperately looking forward to the county bringing back on April 1. With that being said, I do have to also acknowledge that the the number of departments working on this project, including the Employment Services Agency, ESA. Their work has been phenomenal. Last week, over 900 applications from the existing RMC staff were received, and that department is currently working on to ensure that we get the job offers out and that we're ready, again, to transition those employees to county employment and be ready for day one. So excellent progress to date, and I fully expect that as we go forward that we'll have good news to share with this committee and the full board.
Yes, thank you, Paul. Let's see. Yes, go ahead. Sure. Actually, let me go ask to see, open the public. Any public like to speak on this item?
There are no requests to speak.
I'll go and close the queue to the public. Yes, go ahead, Vice Chair.
Thank you, Chair, and thank you so much. I know what a Herculean effort this is, and it's really exciting, and I really applaud staff for all of their commitment to making this a successful transition. I was just actually recently asked regarding the integration in terms of employees. There's some, I understand, some changes in the representation groups of some of the employees from one to another. As the employees migrate into new positions, I guess, or is there a seniority? Is it, what's the word? Are they able to keep their years of service or seniority as they move into new positions, or how does that part work?
Supervisor, I'm going to turn this over to James. I see his mic's on.
So as employees come into the county system, they're of course subject to the county's collective bargaining agreements with our various unions, and enter the county's civil service system. That's the subject of side letter negotiations with some of the employee unions around how that might be handled. So for example, with RMPA, an agreement was reached that in order to break the ties, so to speak, because all of these employees will have the same start date, that we'll use Board of Nursing registration numbers as kind of a tiebreaker among otherwise, hundreds of nurses that would have the exact same seniority date. And that'll be used for the purposes of, for example, bidding or shift transfers or other things as part of the process. But that's something that has to be agreed upon with each unit. And there's some tricky questions because, right, we operate a whole system. And so you have to not just think about this from the perspective of the new employees coming in, but also all of our existing employees who have been county employees in some cases for many years, some of whom are going to probably seek to transfer into vacant positions, at regional or otherwise. So it's a bit of a complicated thing.
So if their years of service in their current position, does that transfer over? It doesn't?
Does not, no.
Okay, all right, thank you, appreciate that.
That's it. Okay, thank you very much, Paul. Yeah, I don't have any further questions on this. Let's move on to the other items. So receiving report from the public health officer. I know we had a report earlier, but anything else, Dr. Cody?
Thank you. You do have a written report in response to the question about the health officer masking order, and
Right.
I'm happy to answer any follow-up questions you might have about the history or rationale for that.
Sure. Any questions? Nope, seeing none. Thank you very much.
Okay, thank
That's all
you.
we have. So moving next to our Director of Behavioral Health Service Department. Hello there.
Good afternoon, Chair Lee, and welcome Supervisor Ave Koga. Nice to see you. You have my written report for behavioral health. I think the only important piece to add related to NetSmart, my avatar, and that is our system for receiving claims, is the state recently reopened the opportunity for counties to resubmit claims dating back to July of 23 when CalAIM payment reform was initiated. They recognize there are a lot of complexities for all 58 counties to implement, and so they've authorized counties to reopen opportunities to resubmit denied claims. So we're working really closely with our contract providers and our county-operated programs to resubmit and rework those claims. So that creates a really good opportunity for us to seek that revenue and reimbursement for those services. So that concludes my report. Thank you.
Yes, thank you, Dr. Rao. My follow-up question would be, what is the scale? How much are we talking about in terms of these resubmitted claims based on this reopening? How much do you think we might be able to claim or resubmit at this point? Do you have any roundabout numbers?
I don't, but we can certainly get back to you. We're just right now reevaluating the denied claims and working closely with the CCPs and reopening those timeframes for them to resubmit.
Great. Okay, thank
Great,
you.
thank
That's
you.
certainly good news. All right, moving along to our CEO of Valley Health Plan.
Thank you, Chair Lee, and welcome Supervisor Abe-Koga. Very happy to have you here. So you have our written report. Two items I'd like to touch upon. One is that open enrollment for Cover California will go on until January 31st, so we have another week or so. We are doing really well with enrollment. We've enrolled about almost 9,000 new members, so that's looking really good. And then also, we have achieved NCQA accreditation for health plan, and so that was a huge lift on the part of everyone at VHP, and that will be in our next report.
Great, thank you. No further questions? All right, thank you. Then last but not least on our item number 11 is receiving report relating to federal and state health policy and budget landscapes. Good afternoon.
Good afternoon, supervisors. I'm Amy Carta, and the Director of Government Relations for the County of Santa Clara Health System. It's good to see you. And with me is Bert Margolin, and Bert will be providing a report on the federal landscape on both health and budget.
Bert, I know we have a lot of changes coming through, but I hope you could do this fairly succinctly, and really appreciate it. Thank you.
My microphone's not on, so it may be more succinct than I planned, given no microphone. Does this work? Yes, it does.
Yes, it works
Okay,
great.
Thank you.
Bert.
Yes, I'll try to be succinct, and I'll go through sort of some of the high points that we need to be focused on. And high is in quotation marks because, as Mr. Williams suggested, this is a very grim and challenging budget environment. We had a blizzard of executive orders the other day, and they're all very concerning. They provoked a wide range of controversies. None of them directly impacted our mainline healthcare funding, the funding that we're tracking. We know those issues and those challenges are coming, but they aren't part of this initial group of executive orders. The president did issue executive orders on health that rescinded a number of Biden administration orders that dealt with issues of equity and inclusion and dealt with maximizing the ACA instructions to sort of maximize enrollment. They were rescinded. And a lot of that is symbolic, but some of that is very substantive. He did issue one executive order of concern involving public health, the World Health Organization, as Dr. Cody knows, the withdrawal from the World Health Organization, which will have a significant impact if it goes through on our ability to deal with pandemics and for our public health departments here and around the country to address those issues. Another executive order that's quite concerning that wasn't specifically health but impacts health is the immigration executive order. When you talk about the detention and removal of anyone not in the country legally, you're dealing with an impact on the patient population served by the county, and that will be of major, major concern in the weeks and months to come. But on the funding front, our major concern going forward will be the structure of the Medicaid program and changes that have not yet been proposed. I want to emphasize they're not yet proposed, but let me give you a little background on how we get money through Medicaid, and then I'll briefly go through some of the likely proposals or possible proposals that we may have to confront. Medicaid, as you know, is a program run differently in every state based on a federal-state partnership. There are 50 separate programs. For every service that a Medicaid provider does or provides, there's a state contribution matched by a federal dollar. The federal match rate, how much of that dollar comes from the federal government, varies from state to state. It is tied to a measurement of the wealth of the state, which is linked to the per capita cap of people's incomes in that state. So California, which is a relatively wealthy state, has a 50-50 match, and a state like Alabama gets 72 cents on the dollar from the federal government. Another way that Medicaid funding reaches systems like ours is through something called supplemental payments. We have our base Medi-Cal payments are payments tied to a unit of service that's delivered. That's called base Medi-Cal. Deliver a service, get dollars for it. But Santa Clara County and others around the country receive supplemental payments that are there to either make up for the fact that the base payment doesn't cover our costs, they're there to make sure we stay in business, or they're there to help us meet a quality metric or some access metric. They're an important part of our system. So the Trump administration hasn't advanced a funding proposal yet, but ideas are being floated by the House Budget Committee and by other entities in the Congress, and we need to take these proposals very seriously for a number of reasons. First of all, when President Trump in his campaign said, "I'm not going to touch Medicare and Social Security," he was pretty explicit in not saying he wouldn't touch Medicaid. Medicaid was never addressed. In 2017, in the first Trump administration, we had a major assault on the Affordable Care Act, which failed. Shortly thereafter, House and Senate budget staffers on the Republican side began to work pretty seriously on efforts to go after Medicaid when and if they ever retained or regained power in the Congress. And so there's been a lot of work done on ways to cut Medicaid. The homework has been done. They've got this cooked as far as the technical work is concerned. And the last big factor, before I get into some examples briefly, is that the top Republican goal is to extend the Trump tax cuts. That's a $4 trillion cost over 10 years. It requires big offsets. They have to find savings to justify or to sustain the tax cut extension. And Medicaid changes can generate hundreds of billions of dollars fairly easily. House and Senate Republicans are definitely looking at changes in Medicaid to finance the tax cuts. So we don't know what the proposal is going to be specifically, but here briefly are a few of the options. The biggest change would be to turn Medicaid, which is an open-ended entitlement, into a per capita cap program, where again, you would get a fixed amount of money from the federal government based upon the number of enrollees. How does that save money? The federal government would take what we currently receive and they would make our cap be a reduced amount. And then they would have an inflation factor less than our actual cost would be, and that would produce major federal savings, fundamentally change the program, major loss of revenue for us. The capping the program has been a goal since Newt Gingrich has been Speaker. It was originally going to be a block grant. It evolved into per capita cap. Per capita cap's more flexible, but it would trigger, if they proposed it, a formula fight involving 50 states. Very complex formula fight. There are reasons to believe they won't attempt the per capita cap, but we don't know for sure. It will be hard for them to get it approved. The other area of possible action that's somewhat simpler for them is to go back to this match issue. In California, we have a 50-50 match. Other states get a more generous federal match. There are two examples that are being floated by the House Budget Committee as of today as to how the match could be adjusted. The first involves the Affordable Care Act Medicaid expansion, which was part of the ACA's initial enactment. 40 states have expanded the Medicaid population to this larger population of able-bodied adults without children. The ACA, to incentivize states to do the expansion, provides a 90% match. California gets that 90% match. And the Republicans are considering reducing that to our normal match rate, which would be 50-50, not 90. Big loss of revenue for all the states where that would be applied. Another idea involves the issue of the floor. California of match. We get a 50-50 match, that's the floor. No state can get less than 50-50 no matter how wealthy they are. Another idea being floated out there is to change the floor of 50% to perhaps 40%. It would primarily affect again, blue states, the wealthier states, and it may be a tempting proposal for the Republicans to consider. We'll see. As far as supplemental payments are concerned, those are complex formulas that are driven by federal-state negotiations, and it's relatively simple, unfortunately, for in one sense, for the federal government to say we're not going to negotiate those supplemental payments anymore. We're going to pull back. The reason why this may actually be a harder cut to make, though, is lots of red states have aggressively embraced these supplemental payments. Texas is a major utilizer of supplemental payments. So if they were to do this, they'd not only harm California, but they'd harm lots of red states. Hard fight to win. So those are some of the options at a high level. The mechanism will be reconciliation, which is the process by which the Senate can pass a measure like this on a bare 51 vote one party only basis. There's a debate right now about whether there's going to be 2 reconciliation bills or 1 reconciliation bill. We don't know how that will play out, but we do know the process will be kicked off with what's called a budget resolution, where cut targets, reduction targets by policy area are formally memorialized in a resolution passed by the House and then the Senate. And in order to get reconciliation done, they've got to start with that, and we may see action on a budget resolution in the coming weeks. So that's a brief, high-level overview of the threat we face. Happy to respond to questions.
Well, Bert, you're full of good news here today.
Yes, thank you.
Indeed. Okay, yes, James, your light is on.
So I just wanted to emphasize a couple points and add one other additional item. So Medicaid is what we're most concerned about. I agree with all the thoughts that Bert just shared. One additional thing that's breaking news is the nominee for OMB director has said that they intend to impose work rules for Medicaid eligibility, which is something that they tried to do with a couple states that was largely unsuccessful and a bit of an implementation debacle in the couple states where it happened, but that would have a pretty devastating impact as well. So just to add to the long list of Medicaid-related changes that the federal government is going to be looking at, but it's very significant to us given the health system and our very extensive efforts to help make our community healthier by getting people enrolled. So we're going to be putting a lot of resources on paying close attention to what's happening and pursuing whatever avenues we can. But, you know, it's, I appreciate the perspective of, you know, from a logical standpoint, for a lot of these things, they affect wide swaths of the country. In fact, states other than California, in many ways, even more so than California. But you know, I'm not sure that people's logical self-interest is necessarily what's happening in Washington, D.C. anymore.
I very much agree with the notion that logical self-interest is in short supply. No question about that. And I would also like to add that in the first Trump administration, the work requirements were voluntarily sought by certain states. And the few states that voluntarily accepted them, it was a debacle. They didn't work very well. People were cut off coverage. And what's being talked about now is not a voluntary opt-in, but a mandatory requirement for all states. So very onerous if it happens.
Bert, my understanding of Medicaid, simply put, is medical, insurance and funding for our poorest and most vulnerable communities, right? This
Yes.
is just basically medical care for the poor.
Yes.
And by taking money away to fund tax cuts, to me sounds more like reverse Robin Hood, robbing from the poor to pay the rich. I don't know how better way to use that analogy. Do you agree? Or you think this is where it's
I agree, especially if they link it to sustaining or extending the tax cuts for the wealthiest Americans.
Right. And that's if we don't have enough billionaires in this country, right? In any case, just my editorial comment here. Any questions from my vice chair? Nope. Okay. All right. Well, thank you so much, Bert, for the quick work. I mean, there has been a lot of movement from D.C., and certainly I'm sure there'll be a lot more coming in the next few weeks, and I just want to say thank you so much for the quick work. And all this just started on Monday, although it really felt like a few weeks have already gone by, but it's only 3 days, people. In any case, thank you so much again, Bert. Really appreciate it. And yeah, thank you also, Ms. Carter. All right, and I think looking at that, we are coming to the end of our report. So is there a motion to receive the report?
Motion to receive the reports.
And I'll go and second that.
Vice Chairperson Abacoga.
Aye.
Chairperson Lee.
Yes,
Motion
as
carries.
well. And now that gets to the end of the agenda. Currently, the next meeting for our HXC will be held on February 19th at 2 p.m. And on that note, this meeting is now adjourned. I'll see you all then. I don't know what gavel, so I just knocked that. Thank you very much, everybody. Thank you.